Thanks so much. Good morning, everyone. Maritza, that was amazing. And as someone who spends a lot of time with Dennis, that's all I'm going to say. Both of you make me very, very optimistic about the future, so thanks for that. And I'm really inspired by the fact that we're having this conference today, because I think it is hugely important as our country becomes more diverse. So I wanted to talk a little bit about history, not in a terribly boring way, I hope. And then talk about where we're going now. And I also wanted to touch on AI, which right now in the broader healthcare community is seen as the answer to everything. You know, people are buzzing about AI. Many of them actually have no idea what it's about, but never mind. You know, it's like a hot topic now, and so forth. And I'm going to guess that all of you in this room know far, far more than the people who are, you know, standing next to microphones talking about it. But what's really, really, really exciting, and I'm going to quote, I might surprise you, President Reagan, for whom I did not vote, I'll confess, who once said that the secret sauce of this country is our diversity. You know, that how many people have come here to make a new life and to do better, and that is what has made America strong, which is really seriously amazing. So I'm going to guess that discrimination, either overt or unintended, I'll just leave it that way, has been with us for centuries. Now, to be honest, speaking from medicine, for many of those years we didn't know very much, so it wasn't, how would I say, admirable behavior, but we weren't really doing much because science hadn't evolved. The 20th century was a really, really big time. And what really made issues related to health equity incredibly visible was cheap computing power. I know this because I worked at an agency for 22 years called the Agency for Healthcare Research and Quality, which I used to tell people was basically the agency derived from cheap computing power. The reason I say that is prior to maybe 1990-ish, people had studied issues related to discrimination and so forth, but they were impaired by the fact that they were trying to find information about what happened to people medically in paper charts. This takes a lot of time, so one of my favorite studies came out of Birmingham, Alabama, and at the university hospital, some cardiologists were trying to figure out did they treat black and white patients differently. And the short answer was no. And they probably felt really, really good about that. But if you looked at the city of Birmingham, the vast majority of black patients did not get care at the university hospital. They were seen in a public hospital where the situation was quite different. And cheaper computing power, electronic records, and all that made it much, much easier for us to be able to see that. It was almost like moving from maps that were done with compasses and other kinds of things to actually being up in an airplane and being able to look at the whole landscape. So when the Agency for Healthcare Research and Quality was created, now they weren't actually doing this in the name of health equity, but that was a very, very important byproduct, right? They were doing it because the Congress wanted this agency because of work that had been done finding variations in practice, right? If you lived in one county in Vermont, you were more likely to get a tonsillectomy or a hysterectomy than if you lived in a neighboring county. And the question is, what's up there? You know, are some doctors just like surgery happy, or do we lack good evidence about who's likely to benefit? That was really the creation of the agency, which is kind of on life support now, but still hanging in there, thankfully. One of the best studies, so when we started looking at very, very large databases, we found disparities associated with race and ethnicity, like literally every single condition everywhere, to the point where you'd be thinking, this is horrible, then we made it available. But to try to get at why, we funded a study in the late 90s where doctors attending a professional meeting. Now, to attend a professional meeting and actually take continuing education seriously, you're already talking about a subset of physicians, right? This was long before you could do it online. And so they're at this meeting and they asked them to participate in this project, and they would see a video of a patient in the clinic. And now, you'd be interacting with that patient, but it wasn't that sophisticated then. And what they did was every doctor saw either a 55-year-old or a 70-year-old, white or black, male or female, right? And the videos had patients use exactly the same words to describe their chest discomfort and so on and so forth. And I'll tell you, this was actually done at Georgetown. And I went over there to look at the videos, and I felt like I was like in the clinic. I mean, they did a very, very nice job. And what they found at the end of the day was the older African-American women, those docs who had seen that patient, were significantly less likely to recommend evidence-based treatment. Now, do you think anyone has any trouble understanding what this study is telling us? No. And we didn't use the word viral those days, right? Early days of the internet. But it created a sensation and a storm, and then the agency was directed to submit to the Congress every year an annual report on quality of care that would include everyone, right? Whether you had insurance or not, and so forth, and an annual report on disparities. So this comes about during an administration, first administration of President George W. Bush, the younger one, and we're getting ready to put this report out, and some of his political appointees are extremely uncomfortable with that. They don't want us using the word disparities. Never mind that the Congress has actually put this in law, that we have to do this. They wanted us to talk about differences, because they somehow thought, the president, who they were serving, would be blamed for this, which was kind of crazy. And what ultimately happened was they created a little controversy around this, because a colleague who at that point ran the Office of Minority Health actually went to the press and said, this is wrong. And let me just tell you, then people were really, really paying attention. Who reads government reports? Well, they were then. And to his credit, the then Secretary of Health and Human Services said, we made a mistake and we're not going to do that. We're going to change back to the original version of the report instead of the, changed language and so forth. And a few weeks later, a Canadian colleague said to me, well, you learned an important lesson. If you want to get a message out, create a controversy, because then people pay attention, right? Who's paying attention to boring scientific papers? And I laughed, but my stomach hurt when he said that. But people did start paying attention more to it. And one of the ways that we went about this, right, was to say, look, there's a growing interest and movement that had begun in the Clinton administration about assessing and reporting on and being transparent about quality of care, right? I don't think dentistry has gotten quite as far in this, but people want to know, should I go to this doctor or should I go to that doctor? And how do I know, and where do I find this information online, and so forth. Now, this leads to, I will say, what can be creative tension. Sometimes it's just tension, because needless to say, doctors are very particular about the specific details, right? What do patients want to know? They want to know, did I get the quality check and the cost check here, right? Or, consumer reports kind of version. So there's always a tension around that, right? Do we use a star rating system so people have a clear understanding of which place is better to get care or something else? But the truth is, if you're looking at the kind of quality of care we're producing, and you're trying to make sure that every patient gets that same level of quality of care, you would target and really prioritize efforts on groups that were less likely to get high quality care, which often tracks with dimensions of equity. And in many cases that worked. So we were feeling kind of optimistic. And then in 2024, the National Academy of Medicine does a report. They had initially done a report in the early 2000s, and what they did was to look back on unequal treatment. And they found that there had been progress, but it was fairly glacial. And I'd love to say that this created an explosion. I don't think that's quite the truth. But what it says to me is that all of you have a very important role in the future in changing that. Now, if I were to go to any clinician and ask them, do you discriminate? Well, what do you think the answer would be? How would they react? No, I treat everybody the same. Never mind that we've got volumes of studies that say that isn't exactly how it works. So I think when we're talking about equity, it's really important to remember all of the potential dimensions, right? Some of which are associated with each other, but not all of them. So it's about race and ethnicity, yes. And health systems that look at their data closely know this. It's also about education. Now we've known, gosh, 40 or 50 years. I remember this, looking at this when I was a resident, right? What happens to people who have a heart attack? You know, when I was growing up, this was a killer. There were a lot of men who just dropped dead in their 40s. We don't see that very much anymore. We've made big strides. We have all these new procedures and medications and so forth, and that's all good news. But a physician up in Rochester, who's sort of a giant in the field, followed a cohort of patients for many, many years. And people who didn't finish high school had worse outcomes, higher mortality rates over time. I don't think we've ever really figured out what that's about. Now, I think most docs have internalized that as, good, we just have to hand out more pamphlets and, explain things to patients. And I think knowing and understanding diseases is a big part of it. How many of you know what self-efficacy is? Anyone want to say a definition? All right, so the shorthand, plain language version, right, is the belief that what you do makes a difference. I mean, we tell people things all the time. But if I believe and I'm motivated to do something about blood pressure and to hang in there if one medicine works a little bit but not enough, and to think about exercise and all that, really, really easy for anyone to tell someone else to do it, right? Actually making change, that's a hard part. It's a really hard part if income is also one of the issues that you're struggling with, and economic conditions, and you're working 2 jobs. When exactly is it that you think, or should a clinician think that you're going to be exercising? Running to the car between jobs or whatever? Not actually going to work. But patients who are motivated and can ask questions and are comfortable enough to just say, if they get what feels like a disrespectful response, this is about me, and Maritza, your description of what this is about and what motivated the doc who helped you so much, that is hugely, hugely powerful. Other issues, of course, are about location. I'm particularly worried about rural communities. I saw an article recently written by a doc who talked about a particularly new procedure they'd used on a patient. This is in an urban, suburban area, and he's worried that there's not going to be enough resources to be able to do that for patients who live in rural communities. Internet access and what I might call digital literacy. One of the fabulous things about COVID was, wow, healthcare had to change fast, as in right now, right? We're afraid for you to come in, both the people providing the care and the people receiving it, so we're going to do telehealth. Now, working at VA, wow, we've been doing telehealth for close to well over 15 years. Now, it wasn't integrated with the main show, and it had its clunky aspects, but we knew how to do this. For many docs, this was a learning experience of a not terribly pleasant kind. On the other hand, they had to and did learn fast because it was the only way that they could communicate with patients, which was amazing. But that doesn't work if you don't have broadband access. And it doesn't work if you are dealing, for example, with patients with sensory impairments of one sort or another, right? A friend of mine told me about her dad, who she was like just sick with worry about because her mother was the main show. I think her parents were like in their 90s, and her mom was hospitalized. So her father's really, really hard of hearing, not very good with the computer, and you know, as a physician, she's trying to keep in touch with him long distance and so on and so forth. But it gives you a little window into issues that we hadn't been thinking about. In Phoenix, the local fire department partnered with our colleagues at the Phoenix VA to actually teach veterans who live alone how to do the telehealth. Now, if you think about it, this is self-interest for them, right? Who are they going to get called about that we've been trying to reach Mr. Jones and we've been banging on the door and he's not answering his phone and all that, so they're going to go in and break in because they're worried about his welfare. And it turns out, you know, on our side, we're saying, well, we set him up for telehealth appointments, but he didn't know how to do it. So people would go on site, go to his home, show him how to do it. Obviously, countless numbers of children and grandchildren have done this for older relatives as well. But that's a big part of it. Language, big, big issue. Sexual orientation, some people are very uncomfortable. Early in my career was when the HIV epidemic peaked, and even before we had names for it, or we knew the virus and so forth, some of my male colleagues, who I admired quite a bit for their ability to take care of patients, this is how they would ask male colleagues about, do you have sex with men? They'd say, do you have any risk factors? And you know, when I figured that out, I thought, you've got to be kidding me. Why can't we just be direct with people? But it's uncomfortable, right? And there are times when it may be that a patient has to speak up and say, I'm worried because. Disabilities, your presentation spoke for itself. It's quite amazing. And I've heard more people talk about bringing parents or older relatives to clinicians' offices, and they're just not set up. Food insecurity. You hear a lot now about food as medicine. That actually dates back to the 1960s, when a lot of people went down south, and some started community health centers down there. And that actually became a national set of facilities that exists to this day. And of course, transportation. And you get there. We've been learning in VA, you know, we have a lot of volunteers who will drive veterans for visits and so on and so forth. And if we can't do the care remotely or virtually, that's very, very helpful. And if you know how to cut the right deal with Uber and Lyft, that's even better, right? Because it's much, much better than having to wait for the other 8 people who came in the same van with you and then have to travel 2 hours back to wherever you're from. So there's a lot of work that remains to be done. And I would argue making docs or health professionals uncomfortable about this is not going to get us very far. I liked the point about continuing education, and we had a sidebar about this at the break. Continuing education, we haven't figured out how to use most effectively, but I have been impressed by courses that the state of Virginia, where I'm licensed, has actually insisted that people take. They have one on opioids. They've been doing, I don't know, 8 or 10 years. And it's a learning opportunity. It's probably smarter if you aren't doing it on the 4th of July, which is when I usually remember because the date when I have to renew is mid-July. But nonetheless, I learned a lot, and I think that is meaningful. And more to the point, you don't get the license renewal unless you actually do the course. So that's one potential problem. And your issue about who you're exposed to, dentists who had worked in settings or seen clinicians serving disabled patients actually tended to have more confidence and be far more comfortable providing care to people with disabilities. It makes me wonder what we could do with simulation because communities are going to be different. I envy all of you because you are attending school and looking towards the future from a far more diverse student population. That's a gift. I stumbled upon quite a bit of this during my medical education because I actually moved around and traveled for clinical rotations. I can also tell you where you might find a place to live for a month in New York and so on and so forth. And some of those were interesting as well. My first adventure was with a blind student at NYU. And that was the two of us and her very large dog in the room, who I was sort of terrified of, because like if I rolled over, he would, he was on full alert all the time. But I also got to see and interact with very different patient populations. Not all future clinicians are going to come from that same background. Again, I think simulation could be very helpful in terms of training, but it's going to take drivers who are coming into the profession to actually get into this. All right, so AI, that can cure everything, right? Well, AI, if it's designed and implemented with good intention, right? About how do we coordinate care more effectively, how do we make it easier for people to access care. I have a good friend who's running a system that is entirely virtual. It's kind of cool, right? And her target audience, if you will, or customer, are single moms at home with kids, some of whom are trying to work and balance childcare and lives. Transportation is an issue, period. Not unlike my own family that I grew up in. So my mother and the pediatrician were like, co-producers here. And all of that is virtual. So there's a lot of opportunities to do things differently in the future. And more systems are using it. Now, unsurprisingly, this country has excelled at all kinds of innovations, and it's very decentralized. But what that means is, if you see a clinician over here where they're using one program and another one in a different setting, because that's where you were referred for additional expertise, their systems may not talk to each other. So you spoke about empowerment and resilience. That's very much going to be a huge driver, I believe, in making sure that we do this. The other issue with AI that makes me very anxious is many of the studies, particularly the large language models are doing, ChatGPT, and are reviewing, right, are themselves inherently biased because they did not, it predates when we wouldn't give funding to researchers who didn't have representative patient samples. Now, again, that's probably not intentional, right? I put an ad in the newspaper, said we're doing a study on whatever, and please come in or call this number, we can give you transportation and all that. But if not all people have that same time and opportunity, you're going to get a skewed population, and we don't know how applicable that's going to be to other patients. That's not to say I'm taking ChatGPT off my phone or anything, but it is to say that we've got to be on guard for that. So I think designed intentionally, it could do some magical things, which I'm very excited about. I've been reading a lot this past week, reviewing applications from people who are trying to improve how we make diagnoses. Which, if you're an internist like me, this is like what you live for. Wow, this is like an important puzzle and all that kind of stuff. But you got to have all the right information, and AI can be a huge help with that. So I'm going to close by first acknowledging the leadership here of Joanna, Elise, and the entire team. You're amazing. Don't stop, please. We need this very much. I'm envisioning a network of these kinds of activities at universities across America, and you'll know it all started here. I don't mean to pile on, but I think this is really a terrific thing to be doing. And part of the reason I think it's so terrific is patients' ability to trust the person who's providing care for them is absolutely imperative. Not a nice thing, and not a nice thing like, do we have a nice little fish tank here in the waiting room or whatever? Do we have free parking? Not to dismiss that. But if I feel like I can trust and work with this clinician, that's gold. And you can't get there unless clinicians have been thinking and working through these issues from the time of their earliest days of training and so forth. I am worried about the Big Beautiful Bill. How many people have heard of the Big Beautiful Bill? Yeah. The one that gave ICE like boatloads of money, among other things. That's going to be really, really tough. We'll see what happens in November, but taking away the ACA Affordable Care Act subsidies is going to be creating a whole lot of hurt, and the Medicaid restrictions are going to be very, very difficult. A few states have had work requirements. Understand that 75 to 80% of people on Medicaid now are already working. But the vast majority of states don't have systems to be able to track this very easily. And the one state that actually reported on their results, Arkansas, found that what they did was that fewer people got Medicaid. Fewer people will be on Medicaid for sure. I'm going to guess that many veterans will then turn to the VA, where I have been working for the past dozen years. And that's a good thing because we can help them out. And that may actually decrease some of the pressure on how many Medicaid recipients can be helped in their state. But restoring those subsidies, and if this sounds like politics, you bet your boots it is, but that's going to have to be part of your agenda as well. Just bearing witness to the impact on patients, because we know what happens. We have studied this before. This is not magic. It's not just going to happen overnight. I mean, there's not going to be some miracle cure. And that's going to be a political fight, and one that people know how to fight for. So, and I think if you're serious about discrimination, you've got to be doing there. And the impact on rural areas, you know, there's this Rural Health Transformation Fund, which I think may delay or postpone some of the issues, but it's still going to be a big, big problem, and that's 25% of Americans. So lots and lots of issues. In case anyone thought that with the Affordable Care Act we solved the problem of health care insurance, it was a big, big victory, but we are not done. So I'm hoping that many of you will remember that. The last thing I would say is, I think in addition to training clinicians and thinking, you know, being very intentional and focused about how do I experience taking care of people who don't look like and think like me and have not lived in the same kind of communities growing up. Again, you know, I mentioned simulation earlier might be helpful. I also think patients are going to be a huge, huge part of this. Now, the good news is, although I used to lecture, persuade, try to be very nice to my own dad about asking questions, I never really got through. A lovely man, a smart man, but you know, I'd call and say, so why exactly did you have a CAT scan at 3 in the morning? Well, the doctor wanted it. Great. So I'm back here trying to play detective from a few hundred miles away. But I think younger people, and people who grew up, even somewhat older than what we sometimes refer to as digital natives, right? I think they're going to approach this with more skepticism, and I think that is actually a good thing. So I think clinicians are going to need to be trained that if someone's asking questions, thank them for it. Open up your arms wide and say, my God, you've got the greatest skill that I can't give you, because it's hugely important. And most of that self-efficacy, right, that motivation that I can own some piece of that is really, really important. So you all, your interest here, being here on a Saturday morning, putting this all together, and frankly, attending a university that is far more diverse than many other universities, give me hope for the future, but please don't stop now. We have made progress, not as much as I'd hoped when I was younger, but the country is different, so we have to be different. So sharing those experiences and sharing what helped people deal with it, sharing how it is that, you know, dentists or other health professionals can have that same kind of confidence and competence, that's going to be hugely important. So if any of you thought that this was just like a presentation for today, and I know you two don't think like that, please take it with you and see if you can get other people on board as well. Thank you from the bottom of my heart for the opportunity to be here today.